Welcome, everyone, and thank you for joining our session today, FHIR on the Horizon. First, let's take a look at FHIR and interoperability through the strategic lens. Recent industry surveys identified that a majority of health plans, slightly more than 60% to be specific, are focused solely on compliance as a near-term milestone, with minimal to no visibility into downstream capabilities. Now, yes, compliance is critical. However, we believe that there's also value in approaching interoperability through the strategic lens to identify additional capabilities across your entire enterprise to accelerate your return on investment into interoperability. Today's session, FHIR on the Horizon, will explore some of the strategic concepts that we believe will be feasible thanks to FHIR. Let's dive in. As I mentioned, our session will focus on a few visionary and conceptual capabilities that we believe can be enabled through the use of FHIR and interop as a whole. First, we'll review the shift to a digital member and patient experience akin to that of other industries. Next, we'll discuss how optimized care delivery is made possible through a longitudinal member record using these new data sets and new data availability across the entire continuum of care. We'll also discuss how health plan enrollment process can be reinvented to increase efficacy of risk stratification while improving the member experience. We will provide insight into how interoperability and FHIR can enable better outcomes in alignment with value-based care as VBC continues to gain its momentum and awareness across the industry. We'll also present the concept of visualizing FHIR resources as part of a patient's record at the point of care. And finally, we will close with an overview of the positive impacts interop and FHIR can have to enable new capabilities within the scope of population health management. Let's go ahead and continue. First, we'd like to review the shift to a member or patient's digital experience. Healthcare customers' expectations have drastically increased over the past 3 to 5 years. Patients and members alike now expect that same level of service and data availability as banking, entertainment, and other retail industries. Interoperability and the underlying FHIR standard are foundational to this shift and maturity across the healthcare industry. Data security has become an increasing focus as healthcare makes this shift to a digital experience. One of the fundamental aspects of this shift and increasing security overall of health data is using industry-leading protocols such as OAuth 2.0 and OpenID Connect, which I'm sure many of you are now familiar with. Further, enabling members and patients to restrict data sharing by FHIR resource will provide additional means of security by truly putting the controls in the patient's hands. The ability to limit specific claim types or resource types would only further this control and provide the patient with additional privacy measures. Speaking of putting control in the member's hands, the interoperability framework is very clear in that the member or patient owns their data. Information blocking, confusing request processes will soon be in our past. Interoperability opens up new capabilities by enabling a member to transport their data as they see appropriate. Now, consent plays a key role in the member's control over their data. Members will have the ability to control which apps, which people or persons, and entities can retrieve and view their data. Scott will share some great insights into the realm of patient consent in just a moment. Through interoperability and the shift to a digital member experience, we also believe that this will decrease costs while improving outcomes. As payers, providers, and members have this increased visibility into claims history and their associated costs, we expect competition to only increase for the purposes of member attainment from a health plan or enhancing the specific experience from a patient perspective. Scott, what are your thoughts on this shift to a digital experience within healthcare?
Well, Seth, you're talking about interoperability and a holistic view of the person, with individuals owning their data and able to see it all, and authorizing their providers to see it too. So I have a question for all of you out there in TV land. How can you deliver holistic, integrated care with caregivers in different roles in different organizations, all centered on the patient, if you can't solve the problem of person consent and data sharing? I submit that you cannot. The problem is the identification and redaction or sharing of diversely coded, potentially sensitive patient data. It's a cumbersome, time-consuming, and expensive administrative burden for healthcare providers and creates a barrier to the integration of medical care across the spectrum. And of course, there are federal and state laws that make it even more complicated. For example, Massachusetts. In Massachusetts, a provider must consider all of the following to determine whether a valid authorization exists to release patient data: the patient's age, legal status, marriage status, pregnancy status, parenting status, as well as who signed the auth, their relationship to the patient, and all of those same factors. Ugh, it's a handful and a mouthful, and it's tough for the computer to figure all that out. Well, providers' perceptions of these complexities as being unresolvable has led organizations deciding not to share anything with others out of fear. The solution is to connect a consent to share capability to your FHIR resources, enabling entities and individuals to specify what information can be shared with whom and for how long. But the what information can be anything sensitive, and sensitivity ought to rest in the control, in the minds, and in the perception of the patient, the member, the consumer. So certainly, 42 CFR Part 2 domains like substance abuse, and then mental health, HIV/AIDS, reproductive health, or even social data, non-clinical social data like homelessness or domestic violence, those things are all pretty sensitive. And of course, coding and value sets are required for this, and they must be current and highly curated. And you need and you're talking tens of thousands of codes, and you really need the community that's agreeing to participate to have a governance process to decide, how to actually implement this, for the population that they serve. So it's a big challenge, but with some collaborators like Seth and ZS, we're taking this on. Seth, back to you.
Thanks, Scott. That's a great perspective. Let's take that one step further on optimized care delivery. We believe that a true longitudinal member record will soon be achievable through FHIR data exchange, member enablement, and overall data portability. The construct of FHIR enables improved consumption and standardization of these broader data types. As we begin managing these new data sets, we can start to see how a 360-degree member record can be composed. Consolidation of all of these data types, including member data, clinical data, and even the Internet of Medical Things data, such as information from an activity device, a Wi-Fi enabled treadmill, or even your smartwatch, is now made possible. Consolidating and managing this data as a longitudinal member record within FHIR will assist providers with predicting patient needs while helping health plans align with members' medical and financial needs. Coordinating care among stakeholders and care providers can finally come to fruition with a three-dimensional record. In a few moments, we'll also tie the concept of this longitudinal three-dimensional record to value-based care and improved outcomes. Scott, what are some of your thoughts on optimizing care delivery through these new data types in alignment with the concept of a longitudinal member record?
Well, to build that store of longitudinal person data from many rivers of information, one needs some industrial strength technical infrastructure. Real-time streaming, able to handle thousands of transactions a second without losing one byte of information. Person identification and authentication, of course, and of course, converting the data to the canonical FHIR resources and housing those resources in our Smile CDR server. And then of course, a pile of APIs exposing the data to the systems of our connected users. But all that's so technical. How do we really make the information usable to the various users that will participate in our data sharing. Let's just take an example, social determinants. Let's say there is a social services organization with a case management system that they use to help their clients with housing or food insecurity, transportation, or social challenges of any kind. That system contains assessments, action plans, services delivered, and outcomes achieved. Let's say on a scale from 0 in crisis to 10, thriving for any dimension of social health. Well, does anybody outside that community-based organization care to see that information? Perhaps the care manager in the accountable care organization at risk? How about the busy PCP with only 15 minutes in the exam room? Or a researcher trying to prove the hypothesis that social health is necessary for physical health and cost containment? Well, with consent, all that is possible. We can grab the discrete data in the FHIR care plan standard, actors, activities, status, outcomes, either store it centrally or make it available through our API gateway using Smart on FHIR, and presto changeo, the connected care provider can see that story right in the EHR or care management system, even if you just start with a shrink-wrapped PDF. And by the way, the view into the information that's important to the PCP that only has a couple minutes to take a peek, probably not going to be drilling all the way down into the discrete data, but wants to see the bottom line. What's the status with the services that are being provided? A care coordinator is going to want to drill down and be able to participate in the interventions that are going to make a difference for that person. And now I have a comment about medication adherence. It's not just about telling the PCP that her patient hasn't picked up the medication, although that's a start. It's much more complicated than that. And with FHIR, we can provide a much richer experience. This is what the prescribing clinician really needs to know. Number one, is the med on the formulary of the health plan that this patient is enrolled in? Is a prior authorization required? What is the patient's insurance benefit and copay? Is there a less expensive med that doesn't need an auth that the patient can actually afford? Imagine all of that information real time available at the point of prescribing right in your EHR system and available to discuss with the patient. That is how you influence medication adherence. Seth, back to you.
Thank you, Scott. Those are excellent examples. Appreciate you sharing those. Next, let's take a look at the enrollment process. The enrollment process can be reinvented and redesigned to enhance risk stratification while providing an improved member experience. In our traditional process model at the point of enrollment, whether that be online, on paper, or even through a broker, a member is prompted to complete an HRA or a health risk assessment. And let's keep in mind that the HRA is dependent upon the member's responses or patient's responses, leaving a lot of room for subjectivity and incomplete health history. By reinventing the enrollment process, we will now or soon have the ability to prompt a member during or even after enrollment to consent to share and retrieve their health data from the prior health plan through that payer-to-payer data exchange. With up to 6 years of historical claims data, a plan can now pair that data with the HRA to more accurately stratify the risk of a given member. How often have they visited the ER? How frequently do they visit their PCP? What are their conditions, diagnoses, and observations identified within FHIR? All of these variables will assist risk and actuarial teams with more accurate stratification and overall risk management. In addition to risk enablement, the enhanced enrollment process would also unlock better outcomes for patients via interoperability. The health plan would then be able to focus on a given member with early intervention programs, deploying a care management team to assist with care transitions, or even targeting members with health and wellness programs based on their actual history. This is all made possible through consent and the payer-to-payer FHIR data exchange. Scott, what's your perspective here?
Well, it's not just payer-to-payer data exchange, of course, though that's a huge leap forward. Imagine a rich repository of claims data, yes, but also clinical data and events and assessments of social health and interventions, all available to assess the health and potential utilization and cost of care for an individual. It's a data scientist's dream come true to access that longitudinal information and be able to predict the likelihood of physical, behavioral, or social problems. And the thing I love about predictive modeling is that you don't need a DeLorean to go back in time to change the future. You can influence your future now with proven evidence-based activities. Seth?
Thank you, Scott. Let's go ahead and move on to value-based care and how FHIR and the principles of interoperability can truly improve outcomes and thus enable better value-based care. Let's talk through an example patient data set and their given data points. Let's say that a patient visits an ER. That emergency room and their providers now have detailed clinical data, including items such as present on admission diagnosis or vitals, and even lab results. After that ER visit, the patient is then admitted as an inpatient, where additional tests, lab results, and procedures are conducted or performed. The inpatient unit now has a robust repository of that patient data. Following the inpatient stay, let's say the patient is then discharged to a rehab facility where they receive additional treatment. That rehab facility is now storing data within their constraints. Meanwhile, the patient also has clinical data from their PCP within the practitioner systems. And additionally, the patient may have other data points such as visits to a minute clinic or an urgent care facility. In its current state, this data is fragmented across various points of care with little to no data sharing and integration. By leveraging interoperability and the underlying FHIR standard, this data will now be with the member and inherently portable from one site of care to another. Aligning and sharing this data across entities will improve patient outcomes, decrease costs such as redundant tests, and offer an improved integrated experience for the patient as they carry through the continuum of care. Scott, what are your thoughts on value-based care and interoperability?
Well, Seth, you're right. It's all about connected care inside and outside one's delivery system. So imagine clicking in your EHR system during a patient encounter and popping up a timeline showing events and encounters for that person, not just office and hospital visits, as Seth says, but LTSS in-home assessments or telehealth sessions with the health plans provider. And you can mouse over any encounter icon, like you see here on the slide, and pop up the provider name and the key data from that encounter, like social determinants of health or illicit drug use if the patient consents. So imagine those icons on the slide here spread out over a timeline so you can scroll back and forth and really see that person's whole story, in the healthcare ecosystem. Well, with another click, I can see the integrated care plan. I'm not talking about aggregated PDF forms from all over the place that I have to read, but a care plan that assembles the data I need to see from multiple sources and I can actually act on, like the health plan's knowledge of medication adherence or quality care gaps and activities that they're recommending I consider to close those gaps. Like, hey, Scott, we see that you have a diagnosis code, an I-10 code from last year for this person. You don't have that code again this year. Get on it, get that person in for a visit. And if that's still relevant, code it, because that drives revenue, that drives your risk score and so on. So that's one of the, one example of what we can do when we have that kind of information. Or how about this? Assessments from the home care nurse telling me, the provider, the prescribing provider, that medication understanding is poor. Perhaps there's a language barrier. Or the action plan created by the social services organization telling me that my patient has arranged access to good food. That's something I want to know, considering the overall health of the person that I'm serving. So you get the idea. It's a whole new world. Finally, enabled by FHIR. Seth?
Thank you, Scott. Moving on, speaking of the interaction at the point of care, let's discuss one of the topics I'm personally excited about, visualizing FHIR resources. Data visualization and providing these personalized experiences are becoming increasingly critical to improving patient outcomes and maintaining health plan membership. We believe that due to the construct of FHIR and its resource-based structure, we will now have a new ability to visualize this data in a way that was previously difficult using linear legacy data. FHIR resources such as diagnosis, observations, procedures can now be leveraged as markers or objects to populate a three-dimensional view of a patient's medical history and their overall current health status. Imagine a patient or provider presenting health history via a mobile device that visualizes FHIR data. At the point of care, a physician would be enabled to accelerate their understanding and review of a patient's health. Traditionally, a provider would review charts, which often include pages and pages of plain text, maybe an MRI, X-ray, or other result. But presenting a visualization such as this of a patient's health will improve the accuracy and breadth of a provider's ability to give care. Scott, how do you feel about health data visualization?
Well, I got to tell you, this visualization and the underlying analytics will be awesome. But can you do this with lousy data? Shoving the data from lab results and pharmacy claims and biometric devices, and especially from CCDAs, all converted to FHIR into a repository is one thing. But can you dump crude oil into your car's gas tank? By the way, about half the lab results are not coded in LOINC. And most clinical informaticists would agree that most CCDs are a mess. Inconsistent coding, if coding at all. Many names for the same drug, missing diagnoses and encounters, and so on. So if you're going to be in the clinical data aggregation and analysis business, you'd better have a strategy for refining the data, normalizing, deduplicating, intelligently organizing, and enriching the data. Wait a minute, Scott, what do you mean enriching? Well, how about interrogating free text using natural language processing and deducing that the clinician is saying something about a heart problem when there's no corresponding diagnosis code in a CCD, or a diagnosis missing meds, or a procedure, or vice versa? Or how about the root cause of the need for a hospital stay, such as a fall in an unsafe home? Well, I'm no clinician, but I'm pretty sure you are going to need a clinical informaticist or two and some data scientists if you want to be in this business. Seth?
Thank you, Scott. Appreciate that perspective. Let's wrap up with population health management as it continues to gain momentum across the healthcare industry. Population health management, or PHM for short, is another capability that we believe can be enhanced through interoperability and FHIR data. We see two primary success drivers for population health management, including health plan levers and provider indicators that assist with achieving outcomes. For value-based care and PHM to be successful, the relationship between plans, providers, and members must be improved and integrated. Interoperability and the portability of FHIR data will inherently improve these relationships across all entities. As providers, payers, and members begin sharing this clinical data through FHIR, a vision of population health management and outcomes become clearer and clearer, such as changes in behavior in a patient or member's diet, their exercise routine, improving the patient or member's health through wellness programs, and decreasing costs, all the while improving quality. Scott, what are your thoughts on PHM, or population health management, and interoperability?
Well, health plans, providers, and the individuals they serve, all informed by data, aided by insights, with everyone understanding the person's goals is fundamental, I think. Not just lower my A1C or address my BMI or reduce my waist size, but I want to dance at my daughter's wedding. I want to dip my toe in the Pacific Ocean before I die. So, really those person-centered, human-centered goals that we all ought to understand if we're going to serve that person. I like to call it population health management, one person at a time. And to provide quality care, we need to provide a cohesive, pleasant, and value-added experience for our customers. You cannot do that without a common language and real-time interoperability. Like I get when I use my Amex card with Amazon and the FedEx van shows up in 2 hours with my package, or my debit card in Italy. Those are cohesive experiences. Well, and those are interesting examples, but I would submit that those interactions are pretty trivial, actually, when compared to the complexity of human health and healthcare. But we finally have the standards and the tech tools like Smile to disrupt the healthcare status quo and finally put the person in the middle. Seth, want to take us home?
Thank you, Scott. That concludes our view of FHIR on the horizon and some of these future capabilities that we truly believe are now made possible because of FHIR and interoperability data exchanges. We also believe that the opportunities are endless, and we're excited to see these new capabilities come to fruition in the near future. We appreciate your attention and time, and we'll now open it up for questions. Thank you.
Thanks, Seth and Scott. That was an amazing session and so many use cases that cross the entire health system that got me excited about becoming part of the Smile team in the first place. So that was great. So for everyone in this session, it's now time for the Q&A. If you have questions, don't forget, you can post them in the chat and we'll get going. Okay, so we have one already. So this is from Naveed. What are your thoughts on clinical decision support platform interacting with EMRs?
I think there's a lot of opportunity to incorporate CDS in interactions with EMRs through the use of CDS hooks and retrieving that data from a FHIR server, making or overlaying analytics over top of that FHIR data, and then providing those indications or those decision support suggestions back to the EMR and actually integrating them into the provider workflow without interfering or slowing down their overall workflow performance. And I think that's really key to the interaction between the two, is not negatively impacting their workflow or overall performance, so to speak.
Meet the clinician where they're at.
Exactly. Good question.
Okay, I've got one out of my own interest here. So regarding optimizing care delivery through a longitudinal member record, how's this feasible from a member or patient perspective?
I believe that as the Smart on FHIR app market matures, we'll see third-party developers start to create innovative ways to make this data more useful through specific views of the data or true portability of that mobile app data. And I think we'll even see smart apps that can start to individually consume some of this external data, such as IoT or smart device data, for example, and actually include that in their longitudinal member record so that a patient or member can present that at the point of care. But I think the key here is going to be data acquisition in the sense of how can we consume as much health data as possible for a given patient and enable them to share that data as they see appropriate. But I think the feasibility really comes back to overall data availability and smart app maturity and what we can do with those apps.
Just to add on a little bit, the whole patient consent thing is a big deal, as we all know. We're working in Massachusetts, and what we intend to do with the community there is basically present the patient through some sort of a portal with the decisions to be able to specify what information to be shared with whom and for how long. But that's complicated. And so how are we going to coach the person into making those decisions and understanding the implications of that? Another way is to kind of do it real time as the person navigates the healthcare system and, has an encounter, right now. Do I want to share that encounter information with Dr. Jones or social worker Susan? So we got to figure that out, but that's going to be critical, I think, to really, put that longitudinal information that we can aggregate, but can you share it and with whom? We're gonna have to work together to figure that out.
That's great. And there's a response here in the chat. It's not worded as a question, but maybe some healthy skepticism for us. We've been in this for a while. So Shanti is saying, this looks like an ideal healthcare scenario, but the entities need to be on a private cloud and provide the data in a timely manner to have connected care. For example, their LTSS, behavioral health, etc. You have a response to that?
Well, that absolutely right. And it takes a community. So, you have a trusted, a trusted utility that houses FHIR information in the middle there. It's okay, community, plug in your LTSS system, plug in your home care system, plug in your EHR from your hospital or your PCP, and together we can collaborate. So that has to be done, and you still have the, kind of the interface challenge. But as EHR vendors and other application vendors adopt FHIR, those connections are going to be a lot easier than they used to be back in the HL7 or the IHE days, which still exists very much, as we all know. But we got a real chance to create interoperability the way we've envisioned it for some number of years. Seth, thoughts?
Yeah, I couldn't agree more. I think it really comes down to the collaboration. And while that's a heavy lift when we look at cross-entity collaboration, I think as we continue to gain maturity and momentum on interoperability, we'll see more payers and providers coming to the table willing to share this data and collaborate on outcomes, for example. So great point.
A nice comment, Shanti. We've got another one, a question from our friend Drew Hanna. The question is, do you see a significant change to payer-provider contracts coming that includes specifics around FHIR data? Do you have any examples of this?
I don't have any examples, but I think it is coming, and so if I'm a payer and I've got a provider network and we want to collaborate, we want to partner for value-based care and share risk, we've got to be able to talk together and talk FHIR. So I don't know how that's going to manifest itself in contracting, but I'm pretty sure it will, because this is going to be the way that we communicate with each other.
Agreed. I mean, I could see providers possibly being incentivized for essentially opening up APIs and allowing direct access or sharing of data between a payer. But I think that's definitely forward thinking as far as how provider contracts could be impacted by this realm of interoperability. Really good question.
Well, and who should pay? Who should pay for that thing in the middle, that utility that's going to liquefy all this information from all these information silos? Well, I guess the question is, who's taking the risk for that population of people, and who's sharing the risk? And is, so whether it's an ACO or an MCO or a provider organization, that's a good question. I'm not sure every provider ought to be paying a fee to plug in to communicate. Uber, I don't think Uber, requires their drivers to pay a fee. to drive an Uber car. So, you know, there might be a model that's something like that out there in the future. If the community can come together and agree how to partner to share risk and economic value that gets created.
Thank you. Let me just have a look at this one that's just came in here. Do you foresee issues with patients having control over which encounters are shared with which healthcare providers? It would seem that for primary care ER physicians, understanding all of the patient encounters are relevant to proper treatment. So should patients always be given the power of consent over which information is shared, or can providers override this?
Yeah, personally, I don't feel that providers should be able to override this. I think one of the overarching concepts of interoperability is really putting that control in the patient's hands, or members' hands for that matter. It's their data, they own it. Now, there's an argument to be made that the more data you share, the better the outcome would be, the better transparency and visibility that provider would have into providing you with appropriate care. But again, this really comes back to the data now being in their hands and controlled by the patient themselves.
I mean, there's a lot of resistance to sharing information today, especially for those organizations who might have a substance use treatment facility, along with a million other things that they do. And a lot of folks say, we're not sharing anything because of the risk of some sort of a breach, some kind of an exposure. But I totally agree with Seth. It ought to be, the decision ought to be in the hands of the patient. But we're going to have to get through those who would block information sharing, worried about some sort of liability, you know, that could exist. So this isn't going to be figured out by next Tuesday, but together I think we can, you know, one community at a time, maybe we can actually start to tip the scales.
That's great. We've got another meaty one from Shanti. So HRAs have to be conducted with the consent. The member needs to be called 3 times over the phone, mail, etc., as per the regulations. The members can refuse to communicate in an assessment honestly. The case managers currently have a hard time working with the members and providers to come up with the solutions within the timeline specified by CMS. What is the solution? What's the timeline? That's a big one.
That is a big one. Yeah, I really think this just points back to the payer-to-payer data exchange and enabling the ability to retrieve a member's prior health history and prior claims data, and really starting to understand that member from a 360-degree perspective. Now, I know that's kind of a high-level solution and doesn't detail the implementation side of it, but I really think that just points back to the payer-to-payer data exchange and how this can start to cohesively come together to achieve that goal.
Thanks.
I think you're pointing to the underlying problem though of the HRA, in the sense that it's up to a member or patient to fill that out, you know, within their convenience and the amount of data they're willing to share versus actually retrieving that data from a historical perspective, which would really shift that whole risk stratification idea.
You know, there's a bunch of life insurance companies are trying to do the underwriting to assess the risk of, you know, a person and how long that person's going to live and so on. Well, big trend. They all saying, hey, I want clinical data from the EHR systems. And they're asking the person, you know, right there, the underwriters across the desk, is it okay? Will you give me a permission to go fish your data out of Epic or Cerner or Allscripts or whatever, wherever? Okay, sure. If I want a quote, okay, bingo. Now that comes in. So, you know, the consent thing is a big deal. In that case, the person consents. If I want life insurance, I got to do it. But yeah, aggregating the data, whether it's payer-to-payer claims, clinical data beyond that, that's the way to do health risk assessment.
Good point.
Okay, we've got a couple more, and this is great, great interactive discussion. Thanks, everyone.
Yes, it is.
From Daya, the vision is fantastic. and it's ideal, but unless the government regulation forces it on mostly the big EMR vendors and prevents them from charging an arm and a leg when opening up their silos, will it remain near impossible to achieve?
I think it may remain difficult to achieve from an EMR standpoint, but I also believe that as more and more EMRs start to open up opportunities to access their silos of data, I think we'll see an increase in competition. And with that increase in competition, we may see a decrease in costs of what it may take to access that siloed data. Yeah, so I think the difficult element is still there, but hopefully with increased competition and overall community buy-in and investment into interoperability, it would become more achievable than it is today and has been historically.
Yeah, agreed. It's been a big problem. It's been a big problem, but I think the ice is starting to melt. At least that's what we're seeing.
Yeah.
There's a question from John. Patients have always made choices about what to share with whom. For example, it's easy to omit conditions, medications, etc., from a health history. The key is that patients need to actually trust the person that they're sharing their data with.
Agreed. That's a really good point. I think, again, that points back to consent. Consent, patients and members may not understand the full scope and impacts of consent, but I think that provides an opportunity to educate them on the value of consent and how we can improve or enhance their experience through the consent process. So instead of tying consent to limiting one aspect or another, we can really focus on those outcomes that we can provide to the patient or member instead.
Question from Nicholas on the idea of EMR vendors and providers needing to be forced through government regulation to achieve this. Are there some use cases where providers, and therefore EMRs, see an incentive to adopt these concepts? I think you mentioned something about risk scores and diagnosis codes. Could you expand on that?
Yeah, if I am a provider, let's say I've got a Medicaid, let's say, that kind of does go to the potential partnership between the payer and the provider. But if the payer is smart, let's say we're talking about Medicare Advantage, the payer gets rated based on closing care gaps, eliminating medication adherence problems, getting five stars based on member surveys and so on, and getting reimbursement based on the diagnosis codes that are coded in the EHR by the clinician in the current year. And if you're missing those codes, it's a big deal. So if I'm the payer, I talk to my providers in the community and I say, listen, I got a big wad of incentive money if you can work with me to close care gaps and get accurate coding, and we'll share the data. So I got plan data. I know the claims and I know the risk scores and so on. I'll get those to your EHR system and let you know that you're missing diagnosis codes that you had last year. Do you want to consider that? So there's got to be a win-win situation. It can't be one party or the other collecting all the additional revenue, let's say, from 5 stars or from from that coding accuracy. It's you got to share the wealth, is my opinion.
Agreed, Scott. Great points.
And another top-up point in the comments that it's also a lot about transparency and what will happen with the data. Don't try and bypass the trust problem with technology.
It's true.
There's a lot of great discussion in the chat. I feel like I wish I had like 5 lounge chairs to give people up on a stage and get a debate going. And keep them coming. There's one, since I don't have any in the chat right now, I had jotted to myself while listening in, is that, Scott, you spoke about the wicked problem of complexity. You didn't use those terms, but that's what resonated with me around consent. You got to consider based on their geography, age, marital status, a dozen other factors. How do you break that down into solvable pieces, and who leads that?
Well, we're working in Western Massachusetts, and it's the community that leads that. You know, there are a couple big health systems there with a bunch of hospitals. It's still the land of a lot of independent physicians. There are community health centers. There are long-term services and supports companies. There are behavioral health people, and you know, there's a bit of incentive in the Medicaid world coming from Mass Health that basically, you know, incents these folks to work together. Well, that community has come together and they've said, we have got to solve this problem as a team. And then we'll bring our patients along, but let's agree on what we want to do. Do we want to put the decision-making in the hands of the person? Yes, we do. Okay, what's a plan to do that? Well, and what they've done is adopted the SAMHSA a few years ago did a whole consent to share project. It built open source technology. We actually grabbed that and are using that as the foundation for this consent to share, or we call it secure share business. But it takes those providers around the table. We meet at least once a month and decide what codes are, you know, in what sensitive category, so that we can then present that next phase to the patients through a portal to be able to make those decisions. But they're going to need help doing that. And the providers, the community health workers and others will be there to help hold their hands during the process. It's a big deal though, but it can be done. The technology's there. Somebody made the point. It's not the technology, it's the trust. It is the trust, that's for sure.
Great, thank you. Selfishly, I've got another. And Seth, you touched on this when you're speaking about the visualization of FHIR data and bringing that to within the EMR, and you know, one of the earlier questions around clinical decision support. Yeah. So if we're amplifying the amount of information that's available throughout the course of care, how do you deal with that and alert fatigue in tandem?
Yeah, I think it's about making that data more concise instead of expanding out into all of these text-based reports based in multiple locations. If we can consolidate all of that into a very simplified view of a patient's health history, I think that'll accelerate, again, a provider's ability to really drill down into their health and have that one-on-one interaction, more intimate interaction with the patient, rather than, which I've experienced personally as we're talking, panning through multiple pages of history, reading through reports, etc., really trying to consolidate all of that down into one easy to read view. And to your point, not oversaturating the content and just creating that boilerplate view that's really impactful to both the patient and the provider. Good question.
Well, great thoughts. All right. Thank you, everyone, for the great questions and interactive discussion. Thanks so much to Seth and Scott. That was a great session. Thanks to our attendees.